Repertories on predictors and prognosticators of consecutive esotropia after undergoing intermittent exotropia surgery. Consecutive esotropia is a manifest inward deviation developing in a formerly exotropic patient after surgical treatment for exotropia. By convention, more than or equal to 10 prism diopter EG persisting for near or at distance more than 2 weeks after exotropia surgery is considered to be significant. An initial overcorrection after intermittent divergent skin surgery is preferred. However, if it persists for more than 2 weeks, we go ahead with the conservative measure, and if the conservative measure fails, we go ahead with the surgical management. Hence, a thorough history and a good workup with looking into the old photograph, previous surgical summary is needed to plan a consecutive strabismus. Here, we aim to evaluate the clinical features and factors responsible for the onset of consecutive esotropia in patients who underwent surgical correction for intermittent exotropia. It was a retrospective EMR analysis done in all patients presented to the pediatric ophthalmology clinic with the diagnosis of consecutive esotropia from period 2013 to 2024. Previous surgery data was retrieved from discharge summary, photographs, and from the EMR. All patients underwent a detailed ophthalmic evaluation. These are the primary surgery parameters we looked into, that is age at initial surgery, what was the type of exotropia, angle of deviation for distance and near, amount of the primary surgery, and whether the surgery was unilateral or a bilateral LR recession. Among the consecutive esotropia parameter, we looked into any presence of refractive error, any complaints of diplopia, any presence of amblyopia, abduction limitation, any presence of high AC by ratio, oblique overaction with the pattern. Also, we looked at the position of lateral rectus intraoperatively. All patients were given conservative management, and if the esotropia persists more than 3 months with more than 15 prism diopter, we went ahead with the surgical management. And if the angle of deviation was less than 20 prism diopter, we did only one lateral rectus advancement, and if it was more than 20 to 25, we did either bilateral LR advancement or unilateral LR advancement with MR recession, depending upon the distance near disparity. Coming to the results, most of the patients were less than 10-year age, with a mean age 8.33 years. Females outnumbered now steady. Coming to the primary surgery parameters, 4 out of 15 patients had surgery done elsewhere, with a mean age 5.86 years, with 66 patients were less than 5 years. Angle of deviation was almost similar for distance and near. None of them had any significant distance near disparity. Average LR recession was 6.76. 20% had undergone bilateral inferior oblique recession along with the primary surgery, and majority had undergone bilateral lateral rectus recession than a unilateral rectus resect procedure. Coming to the consecutive esotropia parameter, majority of the patients presented within 3 months of onset of consecutive esotropia, and most of them had a intermittent squint and a manifest squint, and angle of deviation was almost similar for distance and near. Coming to the BHV, 20% had diplopia and 40 were suppressed, and hypermetropia predominated, followed by emetropia and myopia, and 13.33 had amblyo, and 13.33 had high AC by ratio. Inferior oblique overaction percent 20%, none had DVD, abduction limitation 26.4%, and 2 had slipped LR muscle. And coming to the management, 26.66% were better with the non-surgical management, and 66.66% required surgical management. Of the non-surgical management, 13.33 were better with hypermetropic correction alone, and 13.33 with high AC by ratio was better with bifocal. Among the surgical management, 60% required unilateral LR advancement, and 6.66% required bilateral LR advancement. One patient now steady had lost to follow-up and presented with large angle ET of more than 50 PD ET and was sent for pediatric neurologic evaluation. These are a few cases. A case of a child with intermittent exotropia, post bilateral LR recession. She developed consecutive ET and underwent left LR advancement, and she's doing good. This child present on post-operative day 5 with large angle ET with abduction limitation and palpebral fissure changes, diagnosed as slipped LR and taken for exploration of LR with LR advancement on the next day, and she's doing good. This is another child who presented, who had a ET for near and had found to have high AC by ratio. He's doing good with bifocal. So we found that after all the conservative and surgical treatment, 60 66.66 patients have regained fusion. However, 13% remain suppressed. Coming to the discussion, younger age at initial surgery because of the immaturity of visual function can lead to consecutive EP. Bilateral LR recession, where LR being the divergence muscle, weakening of the same along with the strong fusional convergence of the young child can lead to a consecutive esotropia. High AC by ratio, because of the poor population, the young child was almost always missed. Amblyopia, because of the imperfect binocularity, can amplify a small post of overcorrection. Missed oblique overaction during initial surgery can lead to an overestimation of exotropia angle, can lead to a post of overcorrection. Inferior oblique recession along with the primary surgery, as obliques are abductors, weakening of the same can produce an ESO drift. Also, consecutive EP of large angle on immediate posterior period, have to think about slip muscle. To conclude, younger age less than 6 years and LR recession of more than 6.5 mm, high AC by ratio and amblyopia are the main risk factors we found in our study. So exercise caution with LR recession more than 6.5 mm young IDS users, as weakening of the divergence in those with strong fusional convergence can trigger consecutive EP and compromise binocularity. In young IDS patients, always go conservative, undercorrect, don't overcorrect. These are the limitations.
Thank you. And the findings are quite important findings that you need in such papers. Most of these cases are operated in your center or they are referred from elsewhere?
Four patients only operated, initial surgery operated elsewhere. Consecutive EP surgery was done at our center.
Okay, so most of the patients were operated in your own center. Yeah, so because I asked, as the average months of intervention was 3 months post initial surgery.
Yeah,
so
that's the time they presented to us.
Okay,
some had lost to follow up. Initially, when they are looking ortho, they missed to come for the frequent follow up, and when later on they comes with the complaints of EP, the twins reappear. The presentation was little late.
Yeah, so the important thing will be to look at the immediate post-op, and if there is any suspicion, sometimes these very young children, it is very difficult to get the correct measurements on the first post-operative day. So it is, if not able to get, then it is better to call them within a week or two and then reassess again, because many of the patients have went into suppression. See, most of the patients in intermittent exotropia are binocular, all of them I would say. This amblyopia was also listed as one of the confounders. Usually intermittent exotropia by itself will never cause amblyopia. So it must have been some added refractive error component or something like that. Some anisometropia must have been there. So if that is the case, then always correct the amblyopia first and then proceed towards the intermittent XT correction. But otherwise, I feel the only part was the intervention should have been much more hurried to regain binocularity.